Yes, perfect. Thank you so much, Dr. Villa. Um, and that is the perfect segue onto my talk. Is it up yet? Okay. Which is what patients and care partners need to know about treating CLL. And I put there and SLL because I don't want to ignore anyone in this room who has SLL. I have many patients with SLL. Please know that every time we say CLL, we mean CLL/SLL, as Dr. Villa said. Yeah, exactly. So here are my disclosures. Similarly, I've received research funding and participated in advisory boards and received honoraria from a number of industry partners, which is very common nowadays in cancer research because we really want to work with our partners to bring these novel therapies to our patients. So I'm going to talk about a number of different things. This is sort of a slide with the overview. I don't know how well you can see the light gray, but first we're going to talk about the different types of CLL and SLL treatments, and they're actually similar across other lymphomas as well. So we'll talk about the broad categories, how to choose the right therapy, treatments at time of relapse. I'll have one brief slide on sequencing of therapies, and then treatments in the pipeline. So we'll start first with the different CLL treatment types, and we can kind of think of these in broad categories, and Dr. Villa alluded to a number of these. So first of all, we have chemotherapy. We have a group of treatment called monoclonal antibodies. We have what we now refer to as more targeted therapy. We have immunotherapy and cellular therapy, and then quite very rarely in CLL, it's actually used more in SLL. Patients might get radiation or surgery, but I'm not going to touch on those. It's very rarely used. So let's start with chemotherapy. We use this word all the time, but I don't know if people always understand exactly what it means. It's actually a very broad term and really refers to drugs that kill any fast-growing cells in the body. So as a positive note, that's cancer cells. Cancer cells are rapidly dividing in our bodies. But on the negative side, it also kills other fast-growing cells, in particular hair. That's why people lose their hair on chemotherapy. It can kill mucosal surfaces or mucosal membranes like the mouth, where people get mucositis, esophagus, people can have nausea, vomiting, GI tract, bowels, diarrhea. And so those are some of the common side effects of chemotherapy. Chemotherapy can also kill the cells in the ovaries and sperm, and not typically in CLL treatment, but in some strong chemotherapies, they can actually cause fertility problems. And then really importantly, chemotherapy can kill normal blood cells because our blood cells are actually normally constantly dividing and replicating. And so that's why you can get lowering of your hemoglobin called anemia or lowering of your platelet counts when you're on chemotherapy. Chemo is often given intravenously, although there are oral types of chemotherapy as well. And the point is that chemo goes through the entire bloodstream, unlike treatments like radiation, which is really limited to one spot, or even surgery to remove a cancer, which is done more in solid tumors. Doesn't work as well in something like CLL, which you've already heard is generally all over the body. So we need treatment that we call it systemic. You might, if you're treated through BC Cancer, you know that we have a group, the whole area for getting chemo is called systemic therapy. That means drugs that go through the whole body. So some common examples of chemotherapy you might have heard of, some of you might have been on, fludarabine, cyclophosphamide, bendamustine, chlorambucil. Those are common chemotherapies used in CLL, and they can be used alone or usually in combination with other drugs. So now moving on to monoclonal antibodies. Excuse me. I wonder if I should grab my water. So we heard a little bit from Dr. Villa about monoclonal antibodies. And really what these are something that are made in our normal immune system that help us fight bacteria and viruses. And I always describe them, think of them like a Y. And their job is to glom on to, say, a bacteria or virus in the body and clear it from the system. So many years ago, scientists actually looked to develop or create antibodies that instead of targeting bacteria and viruses, they target cancer cells. And in CLL, actually one of the first monoclonal antibodies that was ever made was a monoclonal antibody targeting something called CD20. CD20 is like a little tag or it's a protein that's on the surface of normal B cells. And so they've created monoclonal antibodies. There's two main ones, rituximab and obinutuzumab. And these two antibodies glom onto CD20 and clear that from the system. So CD20 is present on normal B cells, but it's also present on CLL cells. So you can imagine, so the positive things about these monoclonal antibodies is through a number of clinical trials, they have demonstrated that these can prolong overall survival when added to chemotherapy. That's how they were first tested. And then now we also know that they can deepen responses when they're added to our more novel targeted therapies. When I say deepen response, what that means is that when somebody gets treated, we look for a response. Usually that means a drop in their white blood cell count, their lymphocyte count, decrease in their lymph nodes, decrease in the size of the spleen. And we aim for something called a complete remission, which is sort of complete disappearance of all these things. But we also have ways to test even more specifically in the cells and in the blood for very minute levels of CLL cells. You might have heard of something called MRD. It stands for minimal residual disease. And if someone is MRD negative, that means we can test down to the lowest level that there's no CLL cells left. So when I say deepen response, it means to try to get a really low level of CLL cells in the body with treatment. The negative things about monoclonal antibodies, first of all, if anyone's ever had them, you know that one of the biggest side effects is that when they're going in, especially the first time, they can cause an allergic type of reaction. People can get flushing, sort of tingling of the lips, for example. They can get fevers, low blood pressure. So we give them very slowly over almost 5 hours the first time. The nurses monitor very closely, stop the infusion if there's any signs of these reactions. We treat the patient, and then we restart it at a bit of a slower rate, and eventually usually can get the whole amount in. And on the subsequent doses, infusion reactions usually aren't a problem. The other thing is that because these CD20 monoclonal antibodies are actually attaching to our normal CD20 B cells and clearing them from the system, it's actually suppressing the immune system. So these drugs can cause immunosuppression, increased risk for infection. And the final piece is that our normal B cells are actually what are part of what helps us develop a response to vaccines. So when we get a vaccine, we need our B cells to start multiplying and making antibodies to that vaccine. Well, if you've had a CD20 monoclonal antibody, usually for the time you're on it and for about 6 months afterwards, maybe up to a year afterwards, you're going to have a decreased response to vaccines. Generally, that's not a big problem. It is why we want people to get vaccines before they start any treatment. But for example, during the COVID-19 pandemic, we really had to rethink. We actually stopped monoclonal antibodies in a number of patients to allow people to get the COVID vaccine and so that they'd have a better response to it. So we use this term a lot in CLL called chemoimmunotherapy. And what this means is combining these two things. So chemotherapy plus your monoclonal antibody is something we call chemoimmunotherapy. And we use the abbreviation CIT. And I have it in another slide, so that's why I'm telling you now. And some examples of this are probably regimens some people might have had. Fludarabine, cyclophosphamide, and rituximab, that's called FCR. In BC, we actually used a lot of just fludarabine with rituximab, so FR. Bendamustine rituximab is BR. And then chlorambucil obinutuzumab is another one that is sometimes used. But the game has changed. As Dr. Villa mentioned, we're moving into this era of targeted new drugs for CLL. And what we mean by target is that instead of killing just any rapidly dividing cell, these cells are now killing a specific target, a specific, usually protein on the cell. And one of the main targets, the first sort of targeted therapy in CLL is drugs that target something called BTK. That stands for Bruton's tyrosine kinase. And the first one that came along was ibrutinib. Then we've got now acalabrutinib, also called Calquence. Now we have zanubrutinib, called Brukinza. And then we have other targeted therapies, and the other big one is something that targets a protein called BCL2, and that's the drug venetoclax or Venclexta. And now, very recently, we're into another group of targeted proteins, targeted drugs, still targeting BTK, but they're slightly different. And I'll talk about that later, but the main drug now in that class is called pirtobrutinib. So just briefly on these Bruton's tyrosine kinase inhibitors, because these are some of the very common drugs that we use for CLL. The first one that was made was ibrutinib, and it completely changed the game for CLL. The treatment changed dramatically when ibrutinib came around. And ibrutinib targets BTK, and this is sort of meant to be a map of all the different kinases we have in the body. These are types of proteins in the body, enzymes that help our cells grow. And BTK is somewhere in here. And so ibrutinib targets right here, this red circle, one of these red circles, but it also targets all these other red circles. And what that's saying is that ibrutinib not only targets the protein we want, which is BTK, but it's also targeting all these other proteins that we don't necessarily need it to target. And what that leads to is the side effects that we see with these drugs. So yes, ibrutinib kills CLL cells, but it also does other things, causes other side effects because it's targeting all these other proteins and these other red things that you see here. So some of the main complications of ibrutinib, and anyone who's been on any BTK inhibitor knows, you're going to get bruising. That's extremely common. Bruises where you don't know where it came from, you didn't hit yourself, you don't remember anything, and you get bruises. You might get little red spots, kind of little small blood vessels breaking, red spots, but there's also risk of more major bleeding. Ibrutinib also causes cardiac problems, heart problems. In particular, it causes high blood pressure, and so we are now aware and need to make sure we monitor blood pressure in people on ibrutinib. And it can cause heart rhythm problems, what we call arrhythmias, and a main one is called atrial fibrillation. And then ibrutinib, when we first started using it, we also found that people just came up, there was all these other side effects that people had. People had diarrhea, they had skin changes, nail changes, joint pains, muscle aches. And sometimes they weren't necessarily severe, but they were constant. And these BTK inhibitors, when we first started using them, particularly ibrutinib, it's used continuously. And when I say continuous, I mean you start it, you take it, and you don't stop unless either your disease starts progressing or these side effects become too much and we decide that we need to stop it. So people can be on these drugs for years, 10 years, more even. And so these side effects can accumulate. So then came along what we call the second generation BTK inhibitors. And this is acalabrutinib and zanubrutinib. And this is just to show kind of in a picture that the main difference of these drugs is that they more specifically target that BTK that we want, so this part right here, with less other red. There is some other red, so they do still have some of the problems like bleeding and bruising, but they have less high blood pressure, less rhythm problems, arrhythmias, and much less of the other GI, skin, nail, joint problems. So then moving on to BCL2 inhibitors. And the main one here is venetoclax. And venetoclax works so well that it kills cells very rapidly. So you can think venetoclax, very rapid cell killing. And that's a good thing because it kills the CLL cells. But what happens is when these cells break open into the blood, when they die and they break open, they release their contents into the blood. They release things like potassium, calcium, phosphate, and they release DNA, which actually then gets broken down into uric acid. And these things can all cause problems on our organs. Uric acid in particular can cause problems on the kidneys, lead to kidney problems, kidney failure. And these electrolytes can cause problems again with the electricity of the heart, the conduction of the heart, and cause things like arrhythmias. And this is something called tumor lysis syndrome. So we need to make sure we try to prevent tumor lysis syndrome when we start patients on venetoclax. We have drugs that can help us. So allopurinol is a drug that reduces uric acid levels. It's actually used for gout, which is a problem with accumulation of uric acid. We have other drugs, something called respiricase. We also give lots of fluids to kind of flush everything out of the system. And then we do this dreaded ramp up. So anybody who's been on venetoclax knows that this is very annoying. What we do is we start the drug at a low dose, and once a week we increase it up to our full target dose of 400 milligrams daily. But every time we increase it, we have to do a bunch of blood work. We have to test all of these things to make sure that people aren't having tumor lysis. Because if they are, we need to do something about it. We sometimes have to admit them to hospital, give IV fluids, give more of that allopurinol and respiricase, things like that. So I always say with venetoclax, it's a short-term pain for long-term gain. It's very intensive at the start. You have to keep coming back and forth to the lab. You have to wait for a phone call that you're allowed to take your next dose. You have to, you keep changing the dose. Once you get through that first 5-week period, in general, what I've seen from a number of patients who've been on venetoclax is it's pretty smooth sailing after that. After you're at that level, there's actually not too many side effects of venetoclax. There are some, but most people tolerate it very well, and you can continue on that dose. So when these drugs first came out, they were both the BTK inhibitors and the BCL2 inhibitors, so venetoclax. They were given for continuous treatment. So you start it and you stay on it for years if you're tolerating it well. But now we've moved into this era of fixed duration therapy. And this is a term you're going to hear more and more in CLL. And the whole point of fixed duration therapy, the concept is, what if we combine these drugs together? And they've been able to show that that actually leads to deeper remissions, more of those MRD negative remissions. And then we feel more comfortable stopping therapy. So instead of giving you treatment for 8 years continuously, let's give it for a short period of time, usually 12 to 15 months, and then stop. And so there's 3 main fixed duration regimens that we have available for us here in BC. So we have venetoclax and obinutuzumab, which was the first one that came along. That's for 12 months. We have then the next one that was sort of studied in clinical trials used the original version of BTK inhibitors, so ibrutinib plus venetoclax. And now, only in the last year, have we had the clinical trial data to confirm, and then also had Health Canada approval of the combination of acalabrutinib with venetoclax, also given for 15 months. So we really have a very exciting changing landscape of CLL therapy. So I mentioned, and certainly when I started in this field, chemoimmunotherapy was the mainstay of treatment. That was considered the Cadillac of treatment. FCR or BR, those were new drugs. Adding rituximab to chemo, that was the big news. Then we got into this era of targeted agents. I mentioned I'll talk about pirtobrutinib later. It's only approved in relapsed disease right now. But we have the ones that we mentioned. And now we're into this era of fixed duration therapy. So we have so many options now. It really is an exciting time in the world of CLL, and it's led to it's getting more complicated because we have so many options. So how do you choose the right therapy for you? Well, it's really a shared decision that occurs between you and your physician. And we're always thinking of a number of things when we're thinking about what to recommend for treatment with somebody. So first of all, we want to know what does the data show? What does the science tell us about these drugs? When we look at clinical trials, we're looking at 2 things primarily. Efficacy, which means how well does it work? How long are people staying in remission? How long are they living? And safety. What are the side effects? What's the balance between we want something that works really well, but it also has to be safe and tolerable? We look at prognostic markers. So you heard about those through Dr. Villa. And one of the most important ones that he highlighted is the presence of deletion 17p or TP53 mutations. They kind of refer to the same thing. They're 2 slightly different tests, but we can do those tests. And those tests help guide us in terms of our treatment. We also look at something that we call fitness. And this doesn't mean, how much you can bench press at the gym. That's not what we're talking about here. We're talking about someone's overall medical conditions. What are their other, we use the word comorbidities, but it means what are your other medical problems? Heart disease, you have asthma, diabetes, high blood pressure. What other things are happening? We also do look at how kind of active someone might be, or are they someone who's, hiking all the time, or are they more sedentary, spend their time more at home, resting. So, these kinds of things can factor into what we choose to treat patients with. And then we talk about this concept of values and preferences, but it really means what is important to the person. And this is what we want to hear. This is the conversation we want to have with the patient. What is important to you? Are you someone who says, I can't be bothered with all this complicated ramp up and all these crazy IV infusions. I just want to take a pill, leave, kind of never see you again, and do my thing with this pill. I'm happy to be on it for 10 years. Or are you someone who says, I don't want to be on a pill for the next 10 years. I don't want to be on a drug that will continually expose me to side effects. I want to put in that effort to maybe do that ramp up so that I could shorten my time on treatment. And so these are some of the things we talk about. People, it's what's going on in their lives right now, jobs, travel. Maybe you spend half the year in Palm Springs. Things like this can factor in. We're fortunate we have so many treatment options that we can think about some of these other things to help make the right choice. And then, of course, cost and availability. I will completely echo Dr. Villa's comments here. We are really fortunate in Canada. I truly feel we have the best treatments for CLL that are available. We're fairly quickly getting them to publicly funded options. Sometimes before the governments agree to fund them, the drug companies are actually providing them on compassionate basis. And so we're very fortunate that most of the drugs that we want to treat nowadays are funded in Canada, but there are cases where there's drugs we might want to access that are not funded. Then we have to consider that and whether or not they're available. And unfortunately, there still are slight funding differences across the country. And that's something that is, not what we want in Canada, but unfortunately does exist as healthcare still is provincially decided upon in terms of funding. So I'm now going to attempt to summarize about 15 years of clinical trial research and about 50 different clinical trials in 2 slides. So I'm going to really try to make it simple to think about the big concepts here. So I'm going to talk about different trials that have been done, kind of comparing 2 different options, and then which was the winner, which option won out in that clinical trial. And this is talking about first-line treatment because that's where it's actually pretty complex in CLL right now. So first, there were trials comparing the new drugs, and the first one was the BTK inhibitors, ibrutinib, to chemoimmunotherapy, that's CIT, so FCR or BR or even chlorambucil obinutuzumab. And there have been a number of trials comparing ibrutinib, acalabrutinib, and zanubrutinib to different types of chemoimmunotherapy, and all of them show that the BTK inhibitors win. Then there were trials comparing chemoimmunotherapy to that fixed duration first regimen we had, venetoclax with obinutuzumab. And again, amongst different trials in older patients, younger patients, comparing to different chemotherapy, venetoclax and obinutuzumab wins. Then we've had trials now comparing chemoimmunotherapy to the different combination of a BTK inhibitor, first with ibrutinib, plus a BCL2 inhibitor, venetoclax. So ibrutinib, venetoclax. And here, ibrutinib, venetoclax wins. And then, as I mentioned, most recently, we had a big clinical trial that we participated in Vancouver, comparing chemoimmunotherapy to the second generation acalabrutinib with venetoclax. And here, the acalaven wins out, okay? So in general, clinical trials have consistently shown that these novel agents work better than chemoimmunotherapy in keeping cancer away longer, which is what we refer to as progression-free survival. And in some cases, they have shown that it can help patients live longer, overall survival. But these trials are new. So I know there's many people in the room who've likely had chemoimmunotherapy, and that was the creme of the crop treatment at that time. But this is the way things are changing now. So that was comparing things to chemoimmunotherapy. Well, now people want to know, well, what about between all of these options? What do we know there? So I'm going to talk about those trials here in this second slide. So first of all, we do have trials, these were more done in the relapse setting, that have compared first-generation BTK inhibitors to second-generation BTK inhibitors, acalabrutinib or zanubrutinib. And very clearly, the second-generation BTK inhibitors have won out, particularly in terms of safety and side effects, and in some cases, in terms of efficacy. So in general, at this point, we are no longer using ibrutinib. That's not to say there may be people who've been on ibrutinib or are still on ibrutinib, because if you're tolerating it well, you've been on it for 7 years, we're not making big changes. It's a very good drug. But moving forward, we are choosing the second-generation BTK inhibitors. Then, a controversial question. What about acalabrutinib versus zanubrutinib? And I am going to say that these are equal. There's never been a head-to-head comparison. So the same clinical trial that half of people take one, half of people take the other. There's been many attempts at trying to tease out from the different clinical trials that have been done. Let's take patients who got acala in this trial. Let's take patients who got Zanu in this trial. Let's bring the data together and compare them. There's also been what we call real-world or observational studies, and I think Dr. Scott will speak to this concept of real-world studies in his talk, but really importantly, we've just looked at the general populations, who took Acala, who took Xanu, are there differences between them? And some studies say one thing, some say the other. In general, there is no clear winner between acalabrutinib and zanubrutinib. I think they're both excellent treatment options. There's very slight differences in side effects that your doctor would talk to you about. It also comes down to what that particular center and team are used to prescribing. There's a number of things that come into play, but really both options are excellent options. All right. How about, this was a very big discussion at the most recent large hematology meeting. So we have our big American Society of Hematology meeting occurs in December every year. So this past December, one of the big oral podium presentations, it's called a plenary presentation, was actually on this right here. This concept of comparing a continuous treatment, like a BTK inhibitor, say acalabrutinib or zanubrutinib that you get for years and years and years, versus one of the fixed duration treatments. So either venetoclax obinutuzumab or venetoclax with BTK inhibitor. It was ibrutinib in this case. And the big conclusion is that these were equal, because there had been this feeling that with continuous therapy, maybe that's better. Maybe it is better to stay on treatment for a long, long time and instead of actually stopping and risking the disease progressing. But what this big, large clinical trial through the German CLL study group showed was that these two strategies are equivalent for most patients. They did start to look into slight details. Are there certain patients that did better with one versus the other? And overall and statistically, there's no difference between all the groups so far. This trial's been ongoing about 3 years. But you can see that there is a bit of a trend, and this is the one place where we tend to favor continuous therapy. This is in people with deletion 17p or TP53 mutations, those higher risk patients. It does seem like, at least if they stay on continuous treatment, they do stay in remission longer. We don't really know, though, if they get a fixed duration therapy and then relapse, is that and then go on another drug again, is that worse? Is it worse to start and stop versus being on something the whole time? And we actually don't know the answer to that. So it's not entirely clear, but I would say in general, we prefer the continuous therapies for patients with deletion 17p, unless but it's not wrong to have a fixed duration therapy. If someone really doesn't, wants that, or if it's in a clinical trial setting where we're asking a particular question, I think that it's still very reasonable to have fixed duration therapy with deletion 17p. And then the last one, I know it's getting confusing and it's hard to keep track, but now the question is, what about, these are our two main fixed duration options that we have now. So how do they compare? And there's clinical trials that are ongoing right now evaluating that we don't have an answer to. So to sort of summarize this particular slide, we know that second generation BTK inhibitors are favored over ibrutinib as a single agent. We know that there's no clear difference between acalabrutinib and zanubrutinib. We know that fixed duration treatment is equivalent to continuous BTK monotherapy for most cases. Maybe the deletion 17p is a caveat there. And it's unclear what's better between our different fixed duration options or time-limited options. So what are some of the pros and cons of these different strategies? So I sort of alluded to this before, but let's talk about these continuous treatments. And let's take ibrutinib out now. We're really thinking about acalabrutinib or zanubrutinib. Well, this is pills that you take every day. It's very easy. You go to the doctor, they write a prescription, you go, you pick it up, and you take your pills. And you likely don't need blood work for some time. You don't need to see the doctor very often. It's very simple. It might be better for some patients with higher risk disease, as I mentioned, the deletion 17p. It's unclear, though, if you get started on one of these, can we stop? When can you stop? I have lots of patients who've been on them for 4 years, 5 years, and most of their disease is gone, and they say, can we stop this? It's a great question, and we don't really know from the data that's been out there so far. There are going to be clinical trials evaluating that particular question. As we heard from Dr. Villa's talk, there's the concern of developing resistance mutations. So this concept is similar to the concept of antibiotic resistance, right? The more antibiotics we use, the more the bacteria are going to find a way to evade and fight back and then be able to grow despite the antibiotics. It's the same concept with these drugs. If you're on a drug continuously, the CLL cells try to figure out how to circumvent this. They get mutations. They can learn to grow through that drug over time. And then the side effects, which we've already talked about. Compared to fixed duration regimens, and I again put the most common, the two that we really have now, venetoclax obinutuzumab and acalabrutinib venetoclax. So here, there's no question. It's more intensive. Anytime you get venetoclax in there, you have to do that dreaded ramp up. You have to do a whole bunch of blood work. I will say that that now that we've been doing this for years, and I don't just mean us here, I mean nationally and internationally, there's been very little evidence of tumor lysis syndrome when we do the proper ramp up. And so protocols may change over time to be less intensive. But for now, we're still doing that fairly intensive ramp up. If you get obinutuzumab, it's an IV treatment. You have to come into the center. It's usually once a month for 6 months. There's those infusion reactions. I mentioned there might be a signal that you could be in less time in remission if you have higher risk disease like deletion 17p. But as I mentioned, we're not really sure if there's any downside of starting and stopping treatment over time. It's only 12 to 15 months, and there's less development of resistance mutations. In fact, most of the trials so far show really no development of resistance mutations when patients only take the drug for 12 to 15 months. So that means you could then reuse the drugs again if you progress again down the road. So that's an advantage to fixed duration therapies. And then we talked about some of the side effects. All right, so that was really focused on treatment at frontline therapy. So what about treatment at relapse? And I'm actually only going to spend one slide talking about this because really it entirely depends what you got in first line, and then we just kind of use something else. Or we can even repeat what you got in first line. So the big questions that we ask are, why did treatment stop? Was it because the CLL progressed or grew? Was it because you had side effects and just needed to stop treatment? Or was it planned, like fixed duration therapy? So if it was due to progression, so say you're on a BTK inhibitor and you start progressing, well, then we switch to a different class, like a BCL2 inhibitor, okay? And vice versa. If you started with a BCL2 inhibitor, we can switch to a BTK inhibitor. If you stopped due to side effects, so say you were on acalabrutinib and then you had side effects and you needed to stop, well, when you progress again, we could consider zanubrutinib. We consider the same class, but a different drug that maybe will have a different side effect profile. And if it was planned fixed duration therapy, this is where, similar to what I just said, we don't expect that you'll have resistance mutations. We can likely repeat either of the drugs again, or even both together again if we have funding for that. So these are some of the things that we're going to see over time because these therapies are new, and we're going to see how it evolves over time. As Dr. Villa mentioned, we repeat the prognostic testing, specifically looking to see if somebody has a new deletion 17p or TP53 mutation. And then I mentioned resistance mutations. Should we be testing for these? We are fortunate that our new panel that looks for TP53 mutations, it's a next generation sequencing panel. It does look for BTK and BCL2, some of the common mutations that we see. Again, this is sort of new that we're going to probably be testing for these because we're only starting to repeat treatments over time for patients because these are new treatments. But I think it will become more common to test for this. So then the question of sequencing, and this is a really big topic in the CLL world. Sequencing meaning what order should we do all of this in? We have so many choices. What is the best order? So what do we know about sequencing? Well, I have one slide and I'm going to say not much, and that's the problem. It really is unclear which treatment is better, which is better to have first, which is better to have later. This is a place where these real world and observational studies will really be key to help answer these questions, where we can look at groups who got one versus the other and then how did they do over time. But it's going to take years to figure this out because the good news is that people are doing so well on these new treatments. It's going to take 10 years, 15 years to really see. And by that point, we'll probably have newer drugs. So it might be an old question by that point. And the other good thing, though, is that clinical trials are now building this into their design. So, for example, trials that looked at ibrutinib venetoclax together, they're now monitoring what did patients get at relapse, how are they doing, so that they can look at and compare how patients do at relapse. So at this time, my answer is we don't really know much about sequencing. I think all treatment options are great, and they leave we still have many treatments that relapse, and we're going to be learning about this over time. So my final few minutes, I'm going to talk about treatments in the pipeline. And we have different classes. I'll speak a little bit about pirtobrutinib, which is in this non-covalent BTK inhibitor class. CAR T-cell therapy, I'll speak just briefly about, and then just to list and mention some of the new targeted agents that are coming down the pipeline. So this concept of non-covalent or reversible BTK inhibitors. So the original BTK inhibitors that were developed are covalent, or what we call irreversible BTK inhibitors. That's ibrutinib, acala, and zanu. And this is imagine that this is the BTK protein, okay, in your cell. And this is the drug that's trying to target the BTK protein. Think of this like this is the parking lot, the BTK parking lot, and this is the exact parking spot where ibrutinib, acala, or zanu fits in. And it fits in at this spot called C481. This is an amino acid in this spot. This is where, over time, patients can develop mutations to this C481, and it can mutate, and then the ibrutinib or the BTK inhibitor can't fit in there anymore, and that's where people develop resistance. These non-covalent BTK inhibitors are a bit more, they don't need to be in that exact parking spot. They still come to the parking lot, they still come to inhibit BTK, but they don't need to go into that C481 parking spot. They can go into other parking spots. So they actually can work in patients who've developed mutations or resistance to this C481. And so patients who've developed resistance to these drugs, we've seen in clinical trials that they can then respond to these drugs, these non-covalent BTK inhibitors. So clinical trials have shown that the non-covalent BTK inhibitors are effective in patients with resistance mutations, and pirtobrutinib is now actually Health Canada approved for patients who progress after a covalent BTK inhibitor, so the original BTK inhibitors we talked about, and you have to have had a BCL2 inhibitor like venetoclax because that's another standard of care drug. So right now, ibrutinib's placed in kind of the sequence after those drugs. It's not funded yet in British Columbia, but it is available through the company, through a compassionate access program. And trials are ongoing to kind of move it up in line. Probably soon we'll get to a point where we can give it just after a covalent BTK inhibitor. You might not need to have exposure to venetoclax, but those trials are ongoing, or those decisions are ongoing. What about CAR T-cell therapy? So this CAR T-cell therapy is a bit of a concept of something you could call it a living drug. This is what it's been referred to as. And what happens in CAR T-cells is that T-cells are collected from the patient, and then they're actually sent to a lab, a warehouse really, a manufacturing facility, to a lab where they're genetically engineered to actually fight and attack and kill cancer cells. And in this case, it's your CLL cells. They then they're re-engineered, they're multiplied in the millions to attack the cancer cells, and then they get reinfused back into the patient, and they recognize and kill the cancer cells, okay? So CAR T-cell therapy has been incredible. It's a new therapy that is curative for some lymphomas. There are, however, very significant toxicities. It does require hospitalization. It can be actually quite serious. People can die from CAR T therapy, so it's not something we take lightly. And there have been clinical trials in CLL, and it's actually in the US, it is FDA approved for CLL after treatment with a BTK and BCL2 inhibitor. But the data so far, unfortunately, shows very short remissions, less than 1 year. So for such an intensive therapy with very severe potential toxicities, it's not necessarily the type of remission we want to see. We would really love to see longer remissions. And it's still not curative in this setting for CLL. Some of the reasons why we think that it's not as promising as CLL as it has been in the initial lymphoma trials is because of something Dr. Villa mentioned, that T cells in CLL are exhausted. They're tired from trying to fight off the CLL cells that are continually trying to make them, as he talked about, make that good microenvironment for the CLL cells to live. We know that T cells, from a lot of basic science research, T cells in CLL are exhausted. And so you need T cells. You need good, strong T cells to do CAR T therapy. So now there's studies looking at how can we increase the fitness of these T cells prior to CAR T therapy. And they're actually using drugs like ibrutinib and pirtobrutinib to try to improve. It turns out those actually improve the T cell fitness. And maybe if patients take those around the time of their CAR T, they can have better outcomes. But those studies are still ongoing, and CAR T cell therapy is not approved in Canada at this time. This is one of my final slides. So this is a slide not for you to know any of these numbers or combinations listed here, but just to show how many drugs are in development in CLL. And there's more. This is just a snippet of some of the things in development. And I've divided them into different sections. So probably one of the most exciting groups of drugs are called BTK degraders. So this is now in drugs that instead of blocking, sort of parking the car in that parking spot from BTK, you're actually destroying the entire parking lot. You're degrading the BTK protein entirely. And there's a number of drugs that are in development there. We have a number of clinical trials that are ongoing or current or planned in British Columbia with many of these drugs. And so we do have 2 trials coming up with BTK inhibitors. There was a trial at a different site looking at this other inhibitor, which inhibits the B cell signaling pathway or receptor pathways. There's a whole group of drugs called bispecific T cell engagers. They're also used in lymphomas where they had excellent results. Again, in CLL, the results not as promising as what we saw in other lymphomas because these drugs require T cells, and we know that the T cells are exhausted in CLL, so that same concept. But these drugs, I would say epcoritamab is probably the furthest along in development with CLL. And then we have drugs with there's other ones that will be involved in a clinical trial here as well with one of these bispecific antibodies. And then newer versions of venetoclax. So just like we have second generation BTK inhibitors, we're now getting into, I guess we call them second generation BCL2 inhibitors. And one of the main ones is sonrotoclax that we have a clinical trial with as well. So that's sort of a whirlwind through all the new CLL treatments. We talked about the types of treatments, how to choose therapy, treatments at relapse, sequencing, and treatments in the pipeline. And I want to leave on a really positive note and just show this final slide, which is truly incredible to look at, the evolution of CLL treatment. This is over actually 75 years. But you can see that the first almost 50 years, we had chemotherapy, addition of rituximab, and then very quickly in the last kind of 10 to 15 years, so many more things have been added on, and they're continually being added on. And it really, I think the future is really bright. There's so many new treatments coming. I'm really optimistic about how our patients are doing. We saw some survival curves from Dr. Villa. I think those are, as he mentioned, from a very long time ago. And now we're really in a new era for CLL treatment. So I'll stop there and happy to take a couple questions if we have time. Yes, hi.
I'm just wondering when you think chemo might be deposed as the funded frontline, first-line treatment in British Columbia, and when fixed duration treatments might be available to under 65s.
Yeah, great question. So there's a bit of nuance there. I didn't go into the details, but the first trials that looked at fixed duration treatment were done in older patients. And so it got approved in older patients. And then in Canada in particular, we really hung on to still using chemotherapy for younger, fit patients. And there is reason for that. There are data that show that the chemotherapy works very well in patients with what we call good risk disease. So mutated CLL that Dr. Villa talked about. And so there was a reason. We have good data to show really good long-term outcomes with chemotherapy in that population. But over time, there have now been trials that looked at fixed duration treatment in younger patients. And actually, we do have now access to fixed duration treatment in younger patients. There's a bit of nuances. So mostly it's venetoclax obinutuzumab, but now acalabrutinib venetoclax is not technically funded yet, but it is Health Canada approved, and the acalabrutinib can be accessed through the company. So we actually are able to now, and I would say chemoimmunotherapy is going to be used less and less for CLL across the country. Yeah. Anything? Yes, Warren.
Turn on your mic, please. Turn on your mic.
The mic. Please. I think it went on and then it went off. Perfect.
Okay. I understand sonrotoclax is extraordinary in many, many orders of magnitude more efficacy over venetoclax. Can you comment on that?
Yeah. So certainly initially in vitro, so in the kind of basic lab science studies where they looked at differences between venetoclax and sonrotoclax, it does look like sonrotoclax is much more effective, more cell killing. And the clinical trials are still early. There are comparative trials comparing sonrotoclax to venetoclax that are ongoing, and the early data does look promising. So yeah, we're very excited about it. We just opened a clinical trial here for patients with relapsed CLL with sonrotoclax. Interestingly, the ramp up for sonrotoclax is longer than with venetoclax. So it's actually over 8 weeks. But you only need blood work. Well, you need the blood work once a week. With venetoclax, you actually need it sometimes 3 times when you're about to do the ramp up. So it's overall a bit less blood work. But the idea is that I think if they don't really see a lot of tumor lysis syndrome, they might relax that blood work requirement over time. So hopefully it will not only be more effective, but also easier to take. Yeah.